A very good afternoon to all of you. Today I shall be presenting overview and recent advances in the foot ulcer management. This presentation has been made at the National Conference of Indian Association of Physical Medicine and Rehabilitation, NIMHANS Convention Centre, Bengaluru on 31st of January 2025. Today I shall be talking about the types and etiopathogenesis of foot ulcers, International Working Group on Diabetic Foot 2023 guidelines, recent advances in the foot ulcer management, and the two of the cases I shall be discussing today. I declare that I have no conflict of interest with any commercial product and company, and all the images used in these presentations are with the due consent of my patients. So in India, if you see, we touch the feet of the elderly, we touch the feet of our gurus, our teachers. So in India, in our culture, we have a huge importance for the foot. But if you see for the diabetic, when it comes to the care, especially in the diabetes, Hansen disease and other disorders, this is the worst scenario where it has been neglected like anything. So the most common cause of foot ulcer in India is diabetes, followed by peripheral vascular disease. So I shall be today discussing diabetic foot ulcers as well as venous ulcer, their recent advances and management. So let's start with the first, diabetic foot ulcer. India is one of the leading countries in the world with more than 7.7 crore individuals with diabetes, and the amount is estimated to approximately 13.4 crore by 2045. The data has been published in the year 2021. Diabetes is very much prevalent in India. Its stat says that around 8.9% of Indian population, with an estimated 10 lakh diabetes related death each year our country is facing. So how much diabetic foot ulcers are prevalent in India? So approximately 6.2% of individuals with diabetes in India affected with the diabetic foot ulcers, and the hospital reported higher diabetic foot ulcer rate of around 7.5% than community setting. This is the recent study published in year 2024. So diabetic foot ulcer contribute to approximately 80% of all non-traumatic amputations in India annually. So how much is the financial burden of the diabetic foot ulcers? The study published in year 2024 in the April, it says that the median total annual out of the pocket expenditure is ranging from the 9,000 to approximately 81,000. The medications, ulcer dressings and periodic debridement constitute approximately 80%, and transportation and patient's loss of income are the major non-direct cost which can hamper the whole financial system of the earning family, the member who is the only earning member in the family. So why the diabetic patient get diabetic foot ulcer? So these are simply a triad: diabetic neuropathy, peripheral vascular disease and abnormal foot pressure. All three of them contribute to the diabetic foot ulcers. So what is the pathophysiology of diabetic foot ulcers? The hyperglycemic states lead to the increased action of the enzyme aldolase reductase and sorbitol dehydrogenase, which causes conversion of intracellular glucose to sorbitol and fructose, which leads to decrease in the synthesis of nerve cell myoinositol. Then hyperglycemia, increase in oxidative stress on the nerve cell and increase in vasoconstrictions, leading to ischemia and ultimately nerve cell injury. So neuropathy, why the patients get neuropathy? Because of insensitive and deformed foot, that there is a loss of protective sensation, foot deformities, restricted joint mobility, which leads to abnormal biomechanical loading, which leads to formation of callus and subcutaneous hemorrhage, skin breakdown, and ultimately lead to skin ulceration. So what is the pathophysiology of foot ulcer due to peripheral vascular disease? The persistent hyperglycemia, endothelial cell dysfunction and smooth cell abnormalities, which results into the decrease in the endothelial derived vasodelta, leading to vasoconstriction. Then it leads to increase in thromboxane A2. It's a vasoconstrictor and platelet aggregator agonist, increases plasma hypercoagulability, along with other contributing factors like smoking, hypertension, hyperlipidemia. Leads to occlusive heart arterial diseases, ischemia and ulcer. So to summarize, the diabetic mellitus leads to the peripheral vascular disease is because of cigarette smoking, less frequently ischemic ulcer. The peripheral vascular disease at risk of neuroischemic foot, somatic neuropathy and autonomic neuropathy. Somatic neuropathy causes small muscle wasting, increased foot pressure and leads to the neuroischemic ulcer. I would say autonomic neuropathy leads to decreased sweating, dry skin, formation of callus, and again it leads to the neuropathic ulcers. So these are to summarize the pathways of foot ulceration. So International Working Group on Diabetic Foot, they published guidelines in year 2023. It is a group where all the meta-analysis and systemic analysis has been reviewed by the expert panel, and they form a guideline worldwide. So these are basically 7 guideline or small booklets have been categorized. So we'll discuss in detail one by one. So number 1, foot ulcer prevention. So the guideline says identify the person with at risk of foot, regularly inspect and examine the foot, provide structured education for the patients and family healthcare in the form of patient education, videos, leaflets, etc. Encourage use of appropriate footwear, and we need to find out the at risk of the foot ulceration. Then International Working Group of Diabetic Foot classification guidelines. So the guideline recommended that we are supposed to use the SINBAD classification. This is will be helpful in internal health communication, research formulation, etc. So SINBAD stands for site, ischemia, bacterial infection area, and depth. Or if the ulcer is infected, we need to consider the Wi-Fi wound ischemia foot infection system. Number two, for predicting the outcome of an ulcer in a specific individual, there is no access existing system is available which can say that these ulcers have very good outcome. Then infection guidelines consider hospitalization of all the persons with diabetes who have severe foot of infections. Then we need to find out the inflammatory markers like C-reactive protein, diathrocyte, sedimentation, ESR, procalcitonin, etc. If there is a diabetes related osteomyelitis there, we can go for this MRI, magnetic resonance imaging. Then we need to start the systemic antibiotic regimen as per the cultural antibiotic sensitivity and which has been validated by a clinical trial. Urgent surgical consultation need to be obtained in case of severe infection and ischemia. Consider performing surgical resection of infected bone combined with systemic antibiotics in case of osteomyelitis. Then intersocietal peripheral arterial guidelines. So pedal Doppler with the specific waveforms can be definitely well done. Handheld Dopplers with the specific sound of the handheld Doppler can be obtained. So these are triphasic or biphasic are most of the time normal. In triphasic, positive wave is because of systole, the negative wave is because of early diastole, and again positive wave is because of late diastole. In monophasic, because of vasoconstriction, only systolic waveform is there, and diastolic is obstructed because of vasoconstriction. Then if the person of diabetes with the foot ulcer having gangrene or there is a loss of subcutaneous toe pressure, we can go with transcutaneous oxygen partial pressure measurement system. If the TCPCO2 values are less than 20, then there is abnormality, so we can take a call whether we need to do amputation or need to find out the other modalities like hyperbaric oxygen therapy, etc. Then in case of person with diabetes, peripheral disease, you need to have urgently consult vascular specialist for the same. Then single antiplatelet therapy with the clopidogrel is the first of the choice as compared to the aspirin. Then for offloading guidelines, these are very much important. So the guideline recommended that non-removable knee-high offloading device, that is called total contact casting, is recommended as a first choice of intervention. If the patient is not able to tolerate or any other contraindication for the TCC, then we can go with the removable knee-high cast. Then if still is not available, we can go with the felted foam as a third choice. Then all these things, if non-surgical offloading treatment fails to heal the plantar ulcer, then we can definitely consider for this tendo Achilles lengthening, where we can create a calcaneal foot to prevent metatarsal foot pressure distribution and ulcer, or metatarsal health resection, or joint arthroplasty, etc., etc. In case of clawing of the toe or hammer toes, we can definitely consider for digital flexor tendon tenotomy subcutaneously. Then for wound healing guidelines, do not use any autolytic, biosurgical, hydrosurgical, chemical, or any other thing over the standard of the care. And the standard of the care is sharp debridement, where we are supposed to remove the callus, callosities, and etc., etc. We do not use any form of ultrasonic debridement over standard of the care. Do not use topical antiseptic or antimicrobial dressing, honey, collagen, or alginate dressing, topical phenotine over the standard of the care for the patients of proper healing of diabetic foot ulcers. Then definitely sucrose or octasulfate impregnated dressings are recommended. They form a pseudo layer over the ulcer and it gives a good ulcer healing. Definitely we need to consider for the hyperbaric oxygen therapy or as well as topical oxygen therapy. Do not use any interventions like infrared therapy, like of the physical therapies for proper wound healing. There is no scientific evidence for the same. There is a considered use of autologous leukocytes, platelet and fibrin patch, and diabetic related for the rehabilitated foot ulcers. We can consider for this negative pressure wound therapy system as an adjunct to post debridement of the ulcer. Then for the Charcot guideline, this has new guideline has been added as a seventh chapter of the IWGDF, where if the person is having diabetes mellitus and have intact skin and there is a local rise of temperature, in edema and deformity of the foot, definitely consider for the Charcot neuroarthropathy foot. Consider for the plain X-ray. If you are doubtful on the X-ray, you can definitely go with the MRI. Treatment wise, definitely in active charcoal disease, considered for total contact casting. The recommendation is not for use of alendronate, pamidronate, zoledronic acid, or calcitonin, parathyroid hormone, or methylprednisolone, etc., for the treatment of the active charcoal neuroarthropathy. Foot biological like denosumab is also not recommended. In case of pain and deformity and there is a suspected ulcer, you can definitely go with the surgical fixation with the plates and screw. When the deformity and or joint instability is present, consider for the below knee customized device called charcoal distal orthotic water to be used. Now, second ulcer type, it's called venous ulcers. So the prevalence is approximately 1% of the population. The pathophysiology is venous hypertension lead to chronic inflammatory response. There is extravasation of macromolecules and iron load over the skin. It's called white blood cell extravasation and secretion of inflammatory cytokines. Leads the cytokines transform the phenotype of fibroblast to a contractile phenotype that increases tension in the dermis, where there is a impairment of the impermanent destruction of the dermal tissue repair, and there is a formation of venous ulcer. So treatment point of view, compression therapy is gold standard. Then cleaning, antibiotic and surgical treatment of venous deficiency. Compression therapy, 4-layer bandaging technique is the advised. So I would like to discuss two cases. The first one is a case of venous ulcer. Mrs. ABC, 67-year-old female, housewife by occupation, residing from Nagpur, came with a chief complaint of non-healing chronic ulcer for 20 years. She was apparently alright 20 years back when she got swelling over the left leg. Swelling was associated with itching and redness over the skin. After a few days, skin got broken down and patient developed ulcer. The patient is a known case of varicose vein for 45 years. She was under treatment for same from the local surgeon. No intervention was advised regarding the same. She came to the AIMS Nagpur department in year November 2022. She is a known case of hypertension, taking telmisartan 14 gram OD. And another is in first C-section delivery, she had developed deep venous thrombosis. Again, this caused delay of the surgical intervention. Ulcer examination, size is approximately 6 into 8 into 0.5 centimeter in dimension, or the middle aspect of the left leg with the irregular margin, sloping edges, serious discharge, and surrounding skin indurations with reduced bound discoloration. Distal patches were not palpable. The treatment advice was 4-layer bandaging technique with vitamin C, multivitamin and antioxidant, empiric antibiotic for 3 weeks. So we started advising of 4-layer bandaging technique. The first layer is a soft absorbent material like cotton wool to manage exudate. Second layer was a simple crepe bandage for additional absorption. Third layer is an elastic compression bandage, and fourth is a cohesive bandage. So we like to the overall pressure was to be achieved was around 35 to 40 mm of G. So this was the treatment of the ulcer. First she came into the December approximately 2022, and after 21 weeks of change of 4-layer dressing on every week, the ulcer got finally healed. So it reduces the reduction of backflow of venous blood toward the ulcer, still stimulation of lymph and formation of lymph flow, and compression plays an important role in preventing transient ischemic reperfusion injury to the endothelium. So this was the video. The fourth layer at a distal end pressure is supposed to be more as compared to the proximal one, and figure of it can be applied around the ankle joint. Case 2, this 42-year-old female non-diabetic, non-hypertensive came with the recurrent chronic heel ulcer and deformity for around 18 years. She had a trauma to the right heel, pin prick injury or pointed prick injury. 18 years back, she developed small ulcer with the pus discharge. Ulcer got healed after 2 months of dressing with oral tablets. Patient developed recurrent ulcer after 6 months of healing. She again got operated. Wide debridement has been done. Multiple debridement were done, but ulcer didn't got healed. So on ulcer examination, approximately 4 into 3 into 2 centimeter in size over the right heel with margin irregular, edges punched out. Serious discharge, surrounding skin was innervation and thickened, along with multiple fibrosis scars were there. Distal pulsation were palpable, and X-ray destruction. There is a complete destruction of the calcaneum and subtalar joint. So we simply gave this total contact casting. After 6 weeks, ulcer got healed. But the question was that not of ulcer healing, because in past also ulcer got healed multiple times. So to prevent the recurrent ulcer, we need to offload the foot. So we simply gave low temperature thermoplastic molded footwear along with a sandal to redistribute the weight throughout the foot and prevent the excessive heal recurrence ulcer. So this was the gait of the patient. So this was the latest after 3 months post use of the orthosis. This was the ulcer. So to summarize, diabetic foot ulcers can be prevented with proper foot care advice. In spite of prevention, if still patient develop ulcers, we can, with the comprehensive team management, we can definitely treat the heel ulcers. Venous ulcers have promising result with a 4-layer bandaging technique, and having a good knowledge of offloading, foot biomechanics and ulcer management, the PMR guys or physiatrists can be a better choice for the management of foot ulcer over other specialty doctors. Thank you. Thank you for listening. These are recently inaugurated diabetic foot lab at AIIMS Nagpur. Thank you. Thank you for listening.